Good afternoon, everyone. My name is Dr. Gautam Sachdeva. I'm a neurologist by basic training with a fellowship training in vascular neurology and endovascular neurosurgery. I'm the director of neurovascular program at Sanford Medical Center in Fargo. I'm also a Lifeline Stroke Physician Advisory Committee member. Uh, we are here today to talk about North Dakota transient ischemic attack guidelines, and I'm here to give you an overview. So let's talk about the definition. So transient ischemic attack, what is it? It's an episode of neurological dysfunction which is transient and which is caused by focal brain, spinal cord, or retinal ischemia without any acute infarction. So clot originates either from the heart or the carotid arteries or wherever it's coming from, and it usually dissolves on its own or it gets dislodged. Transient ischemic attack and stroke have a very similar clinical presentation, similar symptoms, and are treated in a very similar manner in the pre-hospital setting. Immediate medical attention is necessary. Patients should receive thorough workup even if their symptoms resolve. Patients with transient ischemic attacks are at a very high risk of early stroke, and their risk may be stratified by using certain scales, like clinical scales, by vascular imaging, and by magnetic resonance imaging with special significance to diffusion weighted imaging. Diagnostic recommendations include the following. The TIA patient should undergo neuroimaging evaluation within 24 hours of symptom onset, preferably with a magnetic resonance imaging including diffusion sequences. Non-invasive imaging of the cervical vasculature as well as of the intracranial vasculature is reasonable. ECG should occur as soon as possible after a TIA, and prolonged cardiac monitoring and echocardiography are reasonable in patients in whom the vascular etiology is not yet identified. The incidence of TIAs in the United States has been estimated to be 200,000 to 500,000 per year, with a population prevalence of 2.3%. That translates into around 5 million individuals. Those are big numbers. So TIA are a warning sign of a future stroke and are considered high-risk events. Do not think of TIA as a mini stroke. It's a misnomer. It misleads the population in believing that they have had a stroke. Think of it as an imminent stroke. 10 to 15% of the patients have a stroke within 3 months, with half of them occurring within the first 48 hours. How do you diagnose a TIA? That's where sometimes it becomes challenging, but the similarities are the symptoms are not any different than a stroke. The only difference is in these cases, the symptoms are transient and they resolve. So, what clinical symptoms are we looking at? So, history of clinical symptoms include the following, but they're not limited to all these: balance, sudden trouble walking, sudden onset dizziness or loss of balance or coordination, eyes, sudden double vision or trouble seeing out of one or both the eyes, face involvement, sudden drooping or numbness on one side of the face, usually the lower part of the face, arm, sudden numbness or weakness of one arm more than the other, especially on one side of the body, and then speech, sudden onset, confusion, trouble talking, expressing yourself, or trouble understanding others. So if you take out the mnemonic from this, it is be fast. The best way to remember it is be fast. B for balance, E for eyes, F for face, A for arm, S for speech, and T is the time to call 911. Complete resolution of symptoms with no active fluctuation. Stable neuroexam and NIH stroke scale without any appreciable deficits as compared to baseline. The important point to diagnose a TIA is two big things. One is that there is complete resolution of symptom with no residual deficits. Second is if you have any brain imaging available, a negative MRI along with complete resolution of symptoms are the two big criteria to call an event a TIA. So what would be important workup in the emergency department itself? Number one, a neurology phone consult or an in-house evaluation if available to determine what is the further plan of action. A CT scan of the head without contrast. What is this done for? Primarily, first of all, to rule out a brain hemorrhage. Second, if you could see signs of early ischemia or the stroke which has already occurred, which tells you that it was more of a stroke rather than a TIA. Ideally, they should be followed by MRI of the brain with special significance to diffusion weighted imaging, which shows you signs of an acute stroke if it's available in-house. The emergent labs. Point of care glucose is very important because hypoglycemia itself can mimic a stroke. So that's the first thing which should be obtained. CBC, BMP, platelets, and coagulation factors including PT, INR, and PTT. Urgent lab include troponins and lipid panel. The 12 lead EKG is recommended because sometimes new onset of atrial fibrillation can be seen in patients who present with these kind of symptoms. Continuous cardiac monitoring for the duration of the ED visit is important, which gives you a very good indication if there is a paroxysmal AFib or any arrhythmias during the stay. Normal saline at 0.9% should be started. The most important factor is if the CAT scan is negative for hemorrhage, you have to let the blood pressure rise, or permissive hypertension is what it's called. In a situation where you are expecting that it was a TIA or a stroke and they are not candidates for the clotbuster medication called TPA, they should have blood pressure goal of less than 220 over 120 for the first 24 hours. You can decrease by 10 to 15% on a daily basis if you decide to admit. Head end of the bed 30 degrees until basic workup is completed. This factor is important because fluctuation in neuro exams have been seen in patients who have internal capsule stroke. It's called capsular warning syndrome. In those situations, it's very important that they lay flat because any changes in positioning can lead to fluctuation in neuro exam and even worsening. If neurology consult confirms that the diagnosis is TIA based on discussion and evaluation by the attending physician, patient should have vascular imaging prior to discharge. If unavailable at the presenting facility, transfer to a primary stroke center plus, a tertiary stroke center, or a comprehensive stroke center should be arranged. A STAT CAT scan angiogram or magnetic resonance angiogram of the head and neck, if available, which qualifies as the non-invasive imaging, should be done. Or if these are not available, at least a carotid ultrasound to look at the extracranial carotid vessels should be obtained. This does not complete the intracranial vessel workup, but at least this gives us an idea of the extracranial carotids to see if there's a high-grade stenosis which needs to be addressed. Based on the above, the neurology service should be reconsulted and vascular imaging should be discussed to see if they have any urgent or emergent further recommendations. What is the transfer criteria for these kind of patients to a primary, a tertiary, or a comprehensive stroke center? If there's abnormal vascular imaging, which qualifies as what? If there's significant intracranial or extracranial atherosclerotic disease, where you're suspecting some sort of an intervention versus at least close observation in an intensive care unit setting, in those cases, the patient should be transferred. If there are ischemic lesions on a CAT scan or an MRI, the diagnosis of stroke is made rather than a TIA. Based on that, patients will require an inpatient complete stroke workup and they would need to be transferred to the above facility. If the patient have had fluctuating symptoms with more than one TIA in the past 1 month, this calls for a transfer so that all imaging and all workup could be obtained as an inpatient. If you are suspecting some sort of a medical instability, which include the following but are not limited to new onset atrial fibrillation, hypertensive emergency, cardiac instability, and any other causes deemed necessary by the emergency room physician or the attending physician. ABCD2 score of 2 to 7. ABCD2 score is a score which was devised to risk stratify the population who has suffered a TIA to quantify the risk of stroke in the next few days to months. A in ABCD stands for age, B stands for blood pressure, C stands for clinical features of a TIA, D stands for duration, the second D stands for diabetes. ABCD score of 0 to 1, but they are unable to complete stroke workup, which cannot be arranged within 7 days based on availability of outpatient neurology provider, urgent openings, or non-compliance suspected. These are the patients which should be transferred to obtain a full workup. ABCD2 score is a risk assessment tool, like I said, which is designed to improve the prediction of a short-term stroke risk after a transient ischemic attack. The score is optimized to predict the risk of stroke within 2 days after a TIA, but also predicts stroke risk within the first 90 days or 3 months. If a patient presents with clinical features not included in the ABCD2 score, make sure you consult with a neurologist, especially in things like posterior circulation strokes, where there could be balance issues, ataxia, and coordination, or especially if vision is involved. So this is the rundown of the ABCD2 score. Age more than equal to 60 scores 1 point. Blood pressure, initial systolic blood pressure of more than equal to 140 millimeters of mercury, or diastolic pressure of more than equal to 90 millimeters of mercury, scores 1 point. Clinical features of TIA. Now they are stratified that if there is unilateral weakness with or without speech impairment, that scores 2 points. If there's speech impairment without unilateral weakness, that scores 1 point. Duration of symptoms. If the duration of symptoms was more than 60 minutes, that scores 2 points. If the TIA duration was 10 to 59 minutes, that scores 1 point. Presence of diabetes scores 1 point. So this makes it a total of 7 points. And this gives us a very good idea of all risk factors included, as well as gives us a good idea of the particular event the patient has had. Following are the predictors of 2-day stroke risk related to the ABCD2 score. Score of 0 to 3, there's a 1% risk. Scores of 4 to 5, there's a 4.1% risk of having a stroke in the next 2 days. Scores of 6 to 7, there's a 8.1% risk of having a stroke in the next 2 days. The ABCD2 score should not be used as a substitute for clinical judgment. So coming back to disposition, all TIA patients should be discussed with the neurology service prior to discharge. Ideally, based on ABCD2 score, if the initial imaging workup is negative, ABCD2 score of 0 to 1 should be referred to neurology clinic in the first 7 days. Now again, like we discussed, this is always based on the availability of a neurology clinic appointment, which could be challenging in some situations. So in those cases, and if you're suspecting that the patient might be non-compliant, it might be a better idea just to send the patient and get the workup done completely at the same visit. ABCD2 score of 2 to 7 are recommended to be admitted to a primary stroke center primary stroke center plus, a tertiary stroke center, or a comprehensive stroke center for complete stroke workup. For patients not currently on antithrombotic therapy with suspicion of a transient ischemic attack and no obvious contraindications to an antithrombotic therapy, aspirin 325 milligrams should be initiated right away. If the decision is made to discharge, transthoracic echo, a fasting lipid panel, a glycated hemoglobin should be ordered prior to outpatient neurology follow-up so that all this information is available for the neurologist following up with the patient prior to the visit. Patients should also be recommended to be scheduled for a 1-week visit with a primary care physician. Just remember, 80% of the strokes after TIA are preventable. It's a good time to act fast.